Welcome everyone, and thank you for joining Parkinson Canada today for our webinar on cognitive impairment and Parkinson's disease. Today's session is being recorded for future viewing and can be accessed by visiting our public website at www.parkinson.ca. Before I introduce our speaker, I have a few housekeeping points. For technical support at any time during today's webinar, click the bottom of the red bar where you'll see technical support, and someone will come online to assist you. You'll have an opportunity to ask questions at the end of the session, and you can submit a question from your computer screen by clicking on the Ask a Question button. Type in your question, and we will make every effort to get through all the questions, and we ask that you keep them to a general nature. Please do not seek medical advice. Today's webinar will be delivered by Dr. Udow, who is currently finishing a fellowship in Cognitive and Movement Disorders Neurology at Sunnybrook Health Sciences Centre in Toronto. His training is supported by a clinical fellowship awarded through Parkinson Canada's research program. Soon he will begin a second fellowship year in Movement Disorders Neurology at the Toronto Western Hospital. Dr. Udow has an interest in Parkinson's disease, dementia, medical education, and doctor-patient communication. Raised in the Manitoba prairies and trained as a neurologist at the University of Manitoba, Dr. Udow looks forward to practicing movement disorders neurology back home in Winnipeg. So, without any further delay, I'll turn it over to Dr. Udow. Thank you.
Thank you. So, hello everyone. I'm Udow, and I'm actually currently a fellow at Toronto Western Hospital, so I have already finished at Sunnybrook. So I'll tell you a little bit more about me. I was a fellow in movement disorders and cognitive neurology at Sunnybrook Hospital, and my fellowship there was funded by Parkinson Canada, and I had a great experience. Before that, I trained as a resident in neurology in Winnipeg, and now I'm a fellow in movement disorders neurology at Toronto Western Hospital. I have no disclosures except to thank Parkinson Canada for having me and for supporting my fellowship. So today I'm going to talk about, first of all, Parkinson's disease and the brain, because I think it's important to have a little bit of a background for some of the other things I'll talk about today. I'll talk about what is cognitive impairment, specifically cognitive impairment in Parkinson's disease. And I'll also touch on dementia with Lewy bodies, which some of you may have questions about. I'll talk about the symptoms of dementia in Parkinson's disease and dementia with Lewy bodies, and then get back to Parkinson's disease in the brain so we can understand what are some of the causes of cognitive impairment in PD. I'll talk about diagnosing and managing cognitive impairment in PD, and a little bit about research and some future directions. So, Parkinson's disease and the brain. So, you may know that Parkinson's disease is a neurodegenerative disease, and this type of disease involves the death of brain cells. And so you see there are three little brain cells there, and the brain is actually made up of billions of these brain cells. The brain cells are very small, and they are what form the structure of the brain. Brain cells themselves are made out of brain proteins, and these proteins are responsible for the structure of brain cells. So for example, they make the walls of the brain cells and also the function of the brain cells. So they allow the brain cells to do what they do best, which is to transmit information from one spot of the brain to another. In Parkinson's disease, brain cell death is caused by an accumulation of toxic proteins. So you see here we have healthy brain proteins. They have nice shapes to them. And then sometimes proteins can turn into these strange folded up shapes where they become toxic. And these toxic proteins tend to clump together in brain cells. And they tend to clump together, and once they do, they become what we call Lewy bodies. Lewy bodies are seen when we look under the microscope at the brains of patients with Parkinson's disease who have passed away. So here you see a healthy brain cell, and And on the right, you see a diseased brain cell which contains those little Lewy bodies, which are made up of the clumped together proteins. Now, scientists don't know why brain proteins become toxic, why brain proteins clump together, or how clumped proteins kill brain cells, and that's something that we're working on. But what we do know is that this brain cell death causes the shrinkage of certain areas of the brain. So you see here healthy brain cells and a healthy brain, and then diseased brain cells causing some shrinkage in different areas of a diseased brain. And in Parkinson's, one of the areas of the brain that shrinks is the area that makes the chemical dopamine. Dopamine is a neurotransmitter, which means it's a chemical that's made by the brain and used by the brain. And it's important to understand about dopamine because dopamine helps the brain move the body. And you can kind of picture it like engine oil. If the engine has enough oil, it runs smoothly and quickly. But without engine oil, the motor will run slowly and shakily and stiffly. And so in Parkinson's disease, because the areas of the brain that make dopamine are being damaged by the neurodegenerative process, the brain has less dopamine in it. Therefore, the brain has trouble moving the body. And this results in the symptoms of Parkinson's disease, which are slowness, stiffness, and shakiness. Damage to other areas in the brain in Parkinson's disease cause other symptoms, including cognitive impairment. So what is cognitive impairment? Well, cognition is the mental process of acquiring knowledge and understanding through thought, experience, and the senses. So for example, when I was coming up with this PowerPoint presentation, I was using some cognitive capabilities. And when I think about sitting at my cabin on Lake Winnipeg in the summer, I'm using my cognition. And when you experience a nice dinner of pasta and tomato sauce, you're also using some cognitive capabilities to be aware of the dinner and to enjoy it. So cognition requires many different complicated mental processes, and these include memory, language, visual spatial ability, and executive function. Memory is the ability to learn and to recall new experiences. So you make long-term memories that you can remember for many years, and you can also remember things for only a short time, like, for example, a phone number. Language is the ability to express thoughts through speech and to understand the speech of others. Visual spatial ability involves navigating around the visual environment and recognizing faces and objects. So the eyes bring visual information to the brain, but the brain must interpret this visual information, and that requires visual spatial ability. And finally, and perhaps most importantly, is executive function. And executive function involves the ability to pay attention, to organize, to plan, to solve problems, and to multitask. Cognitive impairment is when a person has trouble remembering, learning new things, concentrating, or making decisions that affect their everyday life. And cognitive impairment exists on a spectrum. So we have normal cognition, we have normal aging, where you may feel a little bit less sharp, may forget a few words or names here and there, mild cognitive impairment, and finally dementia. And we'll talk about all of these things. So normal aging, as we know, things change with age, and so does cognition. And sometimes as we age, we develop mild problems with multitasking, mild forgetfulness, like I mentioned, troubles with finding names or other words. But this is a normal process, and it can be exacerbated if you have many things on your plate. Mild cognitive impairment is when there are symptoms in one of these cognitive areas, but the symptoms don't cause a loss of day-to-day functioning. So people with mild cognitive impairment can still manage well at home and in the world at large. Dementia is a problem with cognition that results in a loss of normal day-to-day functioning. And people with dementia can have problems in any of the cognitive areas. They could have problems with memory. So for example, forgetting conversations, which may manifest as repeating questions or repeating stories. Losing things like misplacing your phone or your wallet. Forgetting tasks like, for example, taking medications or turning off the sink or the stove. Language problems can occur. People may have troubles forgetting names or words, hesitating or pausing when talking because they can't come up with the next thing they want to say, or some people even have trouble understanding conversations of others or have trouble with reading or writing. Visual spatial problems, so people may get lost in either unfamiliar or even familiar places if they have very bad visual spatial problems. People may not recognize a familiar face and may not even recognize objects, like for example, kitchen utensils like a spatula, or may have trouble finding things in the fridge because they can't sort out through all of the different visual stimuli that there are in the fridge, especially if it's crowded. And finally, executive problems. So this can manifest as trouble with making decisions, with multitasking. So for example, someone may have a hard time cooking and having a conversation at the same time. People with executive problems may have trouble organizing and planning. So for example, packing a bag for a trip, remembering to bring shoes and toiletries and all of the other things that they will need on the trip, and having trouble paying attention as well. So people may find themselves losing the plot of a movie or not paying attention to conversations. Executive function is important for the functioning of all cognitive domains because, as you can see, it involves a whole lot of very higher functions. So let's talk about the specific features of cognitive impairment in Parkinson's disease. In Parkinson's disease, cognitive impairment is mostly caused by problems with the executive functioning, so executive dysfunction. So memory and visual spatial problems can occur, but language is not typically affected. So it's mostly executive functions and some troubles with memory and visual spatial functions. And executive dysfunction can even be a problem early in Parkinson's disease. Even when there's normal cognition, there may be some mild troubles with executive function. Executive function is like the prime minister of the brain. So you must pay attention to many details, sort them out to make important decisions, organize responses to the details, and plan ahead. So these are a lot of very high important functions. Memory problems can happen in Parkinson's disease, but they're different than the memory problems that we see in Alzheimer's disease. So in Alzheimer's disease, the problem is making a new memory. You may have scrambled eggs for breakfast, but not be able to make the memory that you had scrambled eggs for breakfast, and therefore someone may forget that they had what they had for breakfast. In Parkinson's disease, the trouble is with retrieving memories. So that means you've made the memory that you have scrambled eggs for breakfast, but you can't find that memory later on when somebody has asked you what you had for breakfast. And this type of problem, the retrieval problem that we see in Parkinson's, improves with cueing. So for example, if you had scrambled eggs for breakfast but can't retrieve that memory and somebody said, well, what kind of eggs did you have? And then you remember, oh yes, I had scrambled eggs. So that's an example of memory that improves with cueing. Memory problems in Parkinson's disease are probably associated with executive dysfunction. So patients may have problems with attention. So if you're not paying attention to something, you won't make the memory of it, and you won't be able to find the memory later, and then organizing the memory. And a good way to think about this is to think about a librarian. When somebody gives a librarian a book to put back, the librarian knows where to put the book. She's very organized and puts it back in the right spot. And then later, when somebody else asks for that book, she's able to find the book because she put it back in the right spot. But if the librarian has problems with executive function, so trouble paying attention, trouble with organization, and someone gives the librarian a book, she puts it in the wrong place. So she does make the memory, but she doesn't put it in the right place. And later on, she's not able to find that book. And this is the type of memory problem that we see in Parkinson's disease. There are other features, like I mentioned, of cognitive impairment in Parkinson's disease. Visuospatial problems, trouble interpreting the visual environment, happen much later in the disease. And slowing of processing speed can happen even early on in the disease because, as we know, Parkinson's disease is a disease of slowness. So even the mental processes, even thinking, speaking, all of these things can become slower. Other symptoms include hallucinations. So visual hallucinations specifically, seeing things that aren't there, often well-formed images like animals or people. Hallucinations can be associated with cognitive impairment in Parkinson's disease. Delusions or psychosis, so having false persistent beliefs like there's a stranger living in the house or someone stealing from you, can be a symptom of cognitive impairment of Parkinson's disease. And apathy, which is low motivation, fatigue, laziness. This can be another symptom of cognitive impairment in Parkinson's disease. Finally, and really a hallmark of cognitive impairment in Parkinson's disease, are these fluctuations in attention and alertness. And what that means is someone can go from being awake and interactive, and within a few minutes, hours, or from day to day, may be sleepy and staring off into space and inattentive and possibly confused. And then within a few hours or days, they may be awake and interactive again and seem back to their normal self. And these fluctuations are really a big feature of cognitive impairment in Parkinson's disease. Now, there are some things that might make the symptoms of cognitive impairment worse in Parkinson's disease, and these may be reversible. So, for example, if a person had an underlying medical problem like a urine or a lung infection, dehydration, very poor diet, problems with the thyroid function or other hormones in the body, the symptoms of cognitive impairment may be worse. The use of many medications, often specific medications, can also make cognitive impairment worse. Poor sleep can make cognitive impairment worse because if you're very tired, it's hard to think well. And both social and physical inactivity can make cognitive impairment worse. So let's just shift quickly to talk about dementia with Lewy bodies. Dementia with Lewy bodies is similar to Parkinson's disease. There are similar cognitive problems with the executive problem. There are fluctuations of attention and alertness. There are visual hallucinations. And then there are the symptoms of Parkinson's disease, the slowness and the stiffness, although shakiness in dementia with Lewy body tremor is not as likely as it is in Parkinson's disease. Dementia with Lewy bodies also has similar brain changes. There is brain cell death, and there are Lewy bodies found in these dead brain cells. The main difference is that in Parkinson's disease, the slowness, the stiffness, and the shakiness happen first, whereas the dementia, the cognitive impairment, happens later on. In dementia with Lewy bodies, there's cognitive impairment early, and the slowness, stiffness, and shakiness happen later. And importantly, both of these conditions have lots of other symptoms in common. Both of them may start or have early on dream enactment. Both of them can have fluctuations in blood pressure. Both of them can have hallucinations. And both of them can have fluctuations in attention and alertness. So they're very similar conditions. The symptoms are similar. The brain abnormalities are similar. The management is similar. We use the same medications to treat both of these conditions. So in a lot of ways, dementia with Lewy bodies and Parkinson's disease can be seen as two sides of the same coin, or as existing on a spectrum. So let's get back to the brain. What are the changes in the brain that cause cognitive impairment in Parkinson's disease? The healthy brain has a balance of brain chemicals. So not only is dopamine one of the brain chemicals that is important for cognition, but noradrenaline and acetylcholine are two other brain chemicals that are produced by the brain and used by the brain, both of which are important for cognitive functioning. The healthy brain also has this outer layer called the cerebral cortex. And the cerebral cortex is responsible for a lot of our ability to have higher cognitive functions. The cerebral cortex in humans, for example, is thicker than it is in many other animals. So the brain needs both neurotransmitters, these brain chemicals, and the cerebral cortex for higher cognitive function. In Parkinson's disease, there's shrinkage of the cerebral cortex. So as the condition progresses, the outer layer of the brain, that cortex, becomes smaller due to brain cell death. There's also damage to areas of the brain that produce these brain chemicals. So there's not only reduced dopamine, but other neurotransmitters like noradrenaline and acetylcholine are also reduced. And not only do these chemical changes in the brain cause symptoms of cognitive impairment, but they can also cause many of the other symptoms that we see in Parkinson's disease. Slower thinking may be caused by low dopamine levels. Hallucinations may be caused by low acetylcholine levels. Depression may be caused by low serotonin and noradrenaline levels. Similarly, anxiety can be caused by the same low levels of brain chemicals. And apathy or fatigue can be caused by a decrease in all of these different brain chemicals as well. Now, cognitive impairment in Parkinson's disease becomes more prevalent with time. So this is a progressive condition, and as it progresses, cognitive impairment may occur. But the important thing to remember is that it can take a long time. So even after 5 years, there may be only mild cognitive impairment, and true dementia may not set in for 20 years. The other very important thing that I like to say is that every Parkinson's disease brain is different. Some brains only have low levels of dopamine, others have low levels of all the different brain chemicals, and others have more shrinkage of the cortex and more neurodegeneration in other areas as well. And what that means is that some people may get dementia early, even within 5 to 10 years. But the majority of people will have normal cognition for many years and may only towards the end of their condition develop mild cognitive impairment or dementia. So not everybody will get cognitive impairment. How do we make the diagnosis of cognitive impairment in Parkinson's disease? So your neurologist has probably explained to you that there is no test to diagnose whether somebody has Parkinson's disease or dementia with Lewy bodies. So the diagnosis is based on the clinical assessment. For example, in Parkinson's disease, if somebody has symptoms of slowness and shakiness and stiffness and has a good response to levodopa or other dopamine medications, we think the diagnosis of Parkinson's disease is very likely. Dementia is also a clinical diagnosis, and this is diagnosed when we can see cognitive impairment on pen and paper testing, when cognitive impairment causes a decline in function. So someone may not be able to manage from day to day, like paying their bills or managing at home. And importantly, there must be no other explanations for the symptoms of cognitive impairment. So what else could mimic the symptoms of cognitive impairment? Well, any medical illness, like I discussed before, like an infection, imbalance of blood salts or sugars, thyroid or other hormone problems, or vitamin deficiencies, all of these could mimic the symptoms of cognitive impairment. Using certain medications or medication interactions may also cause cognitive impairment. And psychiatric problems, even depression, can sometimes mimic cognitive impairment. And it's important to remember that these causes are reversible. So how do we find evidence of cognitive impairment? What might your doctor do? Well, we may do some neuropsychologic testing, which is typically done with a pen and a paper and assesses different domains of cognition. In the clinic setting, we may do just one screening test. So one piece of paper that tests multiple areas of cognition, but only takes about 10 minutes. But sometimes we may refer patients for a full neuropsychological assessment, which can take hours and is much more detailed and done by neuropsychologists who are professionals at doing this type of testing. Your doctor may have asked you to draw a clock, and that's an example of one of the screening tests that we do for cognitive impairment. Because the clock drawing involves many different cognitive domains. To draw a circle, you must have good visual spatial function. To put the numbers in, you must be able to plan out where the numbers go, where they go in space, and what the sequence they go in. And finally, to put the hands, you also have to have both visual spatial and executive functions to put the hands to the correct time. Other testing your doctor might do are blood tests or brain scans. And the reason to do blood tests are really just to make sure that there are no other medical conditions that could be causing the symptoms, like all those other conditions that I mentioned before, thyroid tests, vitamin levels, sometimes a blood count, looking at the blood salt levels. And brain scans are also helpful. An MRI scan, or magnetic resonance imaging, is a scan that looks very detailed at the structure of the brain. Sometimes a stroke or a brain tumor can cause symptoms of cognitive impairment, although brain tumors very rarely cause this symptom. And so an MRI may be important to make sure that a structural cause isn't contributing to cognitive impairment. Sometimes we order functional brain imaging, which looks at the activity in different areas of the brain, how active different areas of the brain are. So, how do we manage cognitive impairment in Parkinson's disease? Unfortunately, Parkinson's disease is progressive, and it gets worse with time because of the neurodegenerative processes of protein clumping and accumulation and brain cell death. There is no cure for Parkinson's. We don't have any medications that can slow down or stop disease progression at this point, but we are doing research into finding a cure. There is some evidence that active, healthy living can slow disease progression. So what do I mean by that? So exercise is very important. And this includes aerobic exercise like walking, cycling, swimming, or aquafit classes, yoga or tai chi, which are very good for balance, dancing, which is both aerobic and good for balance, and the new boxing programs that are also good for both aerobics and balance. We think that by getting your heart rate up and getting more blood flow to the brain, we may be preventing some of the progression of the condition. Importantly, though, we want you to exercise as tolerated, so don't overdo it. Don't forget about diet. The Mediterranean diet, as it's called, is an important aspect of the Parkinson's disease management. So this is a diet that's high in fruits and vegetables, high in fish and other lean meats, and lower in fattier meats like beef or pork. It's a diet that involves lots of healthy fats, so fats coming from nuts and avocado and from whole grains. So staying away from a lot of those complex refined carbohydrates and a lot of the very highly fattening foods can be important for brain health. And mental activity is very important to prevent the progression of cognitive impairment. And my neuropsychologist friend told me that social interaction is one of the most complicated cognitive tasks. So just being out and speaking with people, your friends, your family, having conversations, that requires quite a bit of cognition. And it's also good for mood to be around people. Things like playing bridge, going out for dinner with your friends or family, going to an opera, reading a book, all of these are examples of mental activity. And keeping up these mental activities are very important for preventing the progression of cognitive impairment in Parkinson's disease. I mentioned sleep. And I'll also mention that sleep can be disturbed in Parkinson's disease. People with Parkinson's disease may wake up frequently to toilet, may have restless leg syndrome, may wear off of their Parkinson's medication in the middle of the night, may have breathing disturbances where they stop breathing in their sleep, may act out their dreams, or may just have anxiety and be unable to fall asleep. And if you're very tired, it's likely that you're not going to be thinking very well. So if you do have sleep problems, there are different things we can do, and so I recommend that you talk to your physician about sleep symptoms. Now, we don't have a cure for Parkinson's, but we do have medications that act to improve the symptoms. And we have lots of different medications. So we do have medications for cognitive impairment that can improve cognition, and these are called cognitive enhancers. And they're a group of drugs that all act in similar ways to increase the levels of certain brain chemicals. In Parkinson's, they can help with attention, alertness, and can sometimes even resolve visual hallucinations. Levodopa-carbidopa, which I understand is 50 years old next year, is the mainstay of treatment of the movement symptoms of Parkinson's disease. But even this medication can help improve cognition. It gives a little kick, so it may help with motivation, attention, and even executive functioning. But we also know that too much levodopa can worsen confusion, so it's a delicate balance that must be managed by your doctors. Mood symptoms are very responsive to antidepressant medications. And in Parkinson's disease, there's a reason for depression, because the brain chemicals for the mood can be low in Parkinson's disease. And these different medications can raise those brain chemicals to improve symptoms of depression and anxiety. And antipsychotics may sometimes be need to used if patients have very troublesome visual hallucinations or troublesome delusions. We may use very small doses of antipsychotics. For those caregivers out there and people with Parkinson's, there are some other things that you can do to cope with symptoms of cognitive impairment. So this includes building supports. So we know that in Parkinson's disease, the memory gets better with cueing. So for example, a support like a medication alarm that beeps when it's time to take your medication will help a person with Parkinson's disease to manage their condition. Structure and routine can be very important to people with Parkinson's disease. And remember to try and keep people with Parkinson's disease engaged before you take away some of their responsibilities. So we encourage that people have active participation in their care with support. For example, being able to manage medications if they're in a blister pack and if they have medication alarms. And finally, it's important to acknowledge that some people may feel self-conscious about their Parkinson's disease, and so it may be hard to engage in a lot of these social activities. We also want to acknowledge that there are many symptoms that can limit function in Parkinson's disease. Aside from the movement problems, there are mood problems like depression and anxiety, and fatigue and apathy, and these can often be an obstacle to getting out and exercising. But these symptoms can be managed by your healthcare professional. And remember that there are changes in the brain that cause this symptom that seems like laziness. There is a real reason in Parkinson's disease why a person with Parkinson's may seem lazy. It's because of the lower brain chemicals. The other thing is that there are supports available. So CCAC, which is the Ontario version of home care, has a self-referral process, and they can help with things like bathing and assessing the home for equipment that may be needed for transportation. There are supports for caregivers, for example, through Parkinson Canada support groups. And importantly, if you're worried about these things, talk to your neurologist. As a neurologist, I know that care for people with Parkinson's disease requires a multidisciplinary team. And that includes people like physiotherapists, occupational therapists, speech and swallowing therapists, social workers, dietitians, and sometimes we refer people to psychiatrists and to neuropsychologists. And so it's important to involve people to care for all different aspects of Parkinson's disease. But I also know that Parkinson's disease requires individualized care because, like I said before, every person with Parkinson's disease is different. And so what works for someone may not work for somebody else. I'm going to end off with some research directions because we often get questions about a cure. And there are two major research directions that I'm going to talk about today, and that's how we may slow or stop disease progression, and the other is how we can predict who would be at risk of developing cognitive impairment. Now, when we talk about slowing or stopping disease progression, we come back to one of the slides that I had at the beginning, which is we don't know why these toxic proteins clump together. We don't know why clumped toxic proteins kill brain cells, and we don't know how to stop this from happening. We do know that these proteins are called alpha-synuclein, and there are scientists working on a vaccine to help to get rid of alpha-synuclein from the brain and other different medications that may be able to reduce the amount of alpha-synuclein levels in the brain. But this is a very complicated process, and it's hard to deliver medications into the brain, and that really limits some of our options. But I'm optimistic that in the future we will have something. In terms of predicting who might develop cognitive impairment, there are different studies going on, and these are called observational studies, where we follow patients with Parkinson's over time and do multiple different assessments. And one such study is called the Ontario Neurodegenerative Disease Research Initiative. This study is following over 600 patients from across the province with all sorts of different neurodegenerative diseases, and they follow them with MRI brain scans, with neuropsychological testing, with evaluations, computerized evaluations of how the eyes move and how people walk. And these types of research are very important to be involved in because they will give us hopefully some idea of how to predict who might be at risk of cognitive impairment in Parkinson's. I'll just make a couple conclusions, and then I'm going to mention one project that I'm working on that's exciting. Cognitive impairment in Parkinson's disease and in dementia with Lewy bodies includes difficulties with executive functions and sometimes later on with visuospatial abilities. And these changes are caused by an imbalance of brain chemicals and shrinkage of brain areas. And management of these symptoms requires a multidisciplinary team and is patient-specific. So I want to give a little plug for a project that I'm working on that some of you listening may be interested in. I'm going to be partnering with Parkinson Canada to develop an educational tool to help physicians discuss Parkinson's disease and cognitive impairment with patients and their caregivers in the clinic setting, using a lot of these illustrations that you've seen today. The idea is that with the help of Parkinson Canada, we will be surveying patients to see what kind of content they may want in this educational tool. And the goal will be to eventually develop an educational resource to benefit both patients and healthcare professionals when discussing some of these complicated issues. So I would ask you to just keep an eye out for further information about this that will be coming from Parkinson Canada. Thank you everyone for your attention, and I'm happy to take some questions.
Thank you, Dr. Udow. You've given us some great information on cognitive impairment in Parkinson's disease, its symptoms, diagnosis, and management. We will now open the forum for questions, and we've got questions already coming in. The first one is, how does having a, quote, number of things on one's plate, unquote, impact cognitive impairment?
So when we talk about having a number of things on one's plate, this refers to executive function. So executive function involves the ability to multitask, to deal with many things at once. So there are two ways that having too many things on one's plate can impact cognitive function. First of all, it may overwhelm the executive abilities of somebody to manage too many things at once. And second is that having too many things to do at once can be very stressful. And as a physician, I know that doing too many things at once can take a big toll. And so it can cause stress, anxiety, fatigue, and all of those symptoms can sometimes alter cognition.
The next question is there a correlation between the existence of MCI and developing dementia later in the disease process?
So that's a good question. MCI, or mild cognitive impairment, in Alzheimer's disease does tend to predict the development of Alzheimer's disease. So in Alzheimer's disease, somebody may start by having mild cognitive impairment, and we know that it's likely that they will develop Alzheimer's disease in time. We don't have the same data for Parkinson's disease and mild cognitive impairment, but it is likely that mild cognitive impairment is a risk factor for developing dementia in the future in Parkinson's disease as well. That being said, it's impossible at this point to predict that anybody with mild cognitive impairment will develop dementia because we don't have blood tests or brain scans or any other clinical variables that we know will help us to make this prediction.
The next question, are auditory hallucinations like hearing religious music a symptom?
So the more common type of hallucination in Parkinson's disease is a visual hallucination, but other sensory hallucinations like auditory hallucinations where people may hear things, or even sensory hallucinations where people may feel things on their skin may also happen, but they are less common than visual hallucinations.
The next question, should there be a baseline MRI to determine future brain appearances, examples, shrinkage of the brain?
So that's also a good question. So the reason to have a baseline MRI would be there would only be a reason to have a baseline MRI if we had better predictors of how someone may progress with Parkinson's disease in terms of brain shrinkage. But there isn't a very good reason to have a baseline MRI at this point because we know that if we did an MRI in the future, we may or may not see brain shrinkage. And brain shrinkage is a very non-specific thing. As we age, our brains shrink, and so the brain MRI of a 90-year-old will look smaller than the brain MRI of a 60-year-old. And so it's very non-specific. Brain shrinkage can also be caused by strokes or other systemic medical conditions. So at this point, there isn't a good reason to have a baseline MRI scan unless there are other things going on. So sometimes patients with Parkinson's disease also have high blood pressure, high cholesterol, diabetes, and may smoke. And these are all risk factors for developing strokes. And multiple little strokes in the brain, which may be completely silent, you may not notice that you've had those strokes, could contribute both to the movement symptoms of Parkinson's disease and the cognitive symptoms of Parkinson's disease. So in some patients, we do order MRI scans to look for things like strokes, but not everybody needs an MRI scan for Parkinson's disease.
Dr. Udow, some consider levodopa to be contraindicated in treating Lewy body. What are your thoughts? So
I will say again, one of my favorite mantras is that every Parkinson's brain is different and every dementia with Lewy body brain is different. Levodopa isn't contraindicated in dementia with Lewy bodies, but we do know that levodopa can contribute to some of the confusion that we see in dementia with Lewy bodies. We also know that patients with dementia with Lewy bodies may have less severe movement symptoms than patients with Parkinson's disease, so they may not need levodopa. So again, it's very patient specific. If a patient with dementia with Lewy bodies has very bad movement symptoms of slowness and stiffness and shakiness, then we may try levodopa. And if levodopa causes worse confusion, we may reduce the dose or stop it. A lot of our treatment in Parkinson's disease and in dementia with Lewy bodies is on a trial and error basis, because we can't predict how any one person will respond to medications. And we do have different genetic studies that hopefully with the development of being able to map the human genome, we may be able to find some genetic markers that may suggest that some people respond to medications in certain ways. But at this point, we don't have any way to be sure. So the approach is that if somebody does have troubling movement symptoms, we would try levodopa, and if levodopa didn't work or caused confusion, then we would stop it. And the confusion that might be caused by levodopa will resolve once the medication is stopped.
And can dementia with Lewy bodies affect speech?
So we have to distinguish between speech and language. So speech is the ability to articulate words, and language is how the brain is able to produce the words, to find the right words to say. So language involves a dictionary in the brain, whereas speech involves more of the muscles. In both Parkinson's disease and dementia with Lewy bodies, there can be changes to the way a person can articulate. So especially in Parkinson's, people may be quieter, may speak a little bit faster, and may slur and mumble a little bit. And the similar thing can occur in dementia with Lewy bodies. In terms of language, in terms of the dictionary, it's very atypical in both dementia with Lewy bodies and Parkinson's to lose pages out of the dictionary. But because of the problems with executive function and paying attention, we could see some hesitations and some forgetfulness of words.
How prevalent is Parkinson's disease in families? Will our children inherit this disease?
That's a good question. So Parkinson's disease is not typically hereditary. As I've said many times, we don't understand why people get Parkinson's disease. And there are some rare forms that are genetic. And typically, those genetic rare forms have a much earlier age of onset. So in the 30s or the 40s than the idiopathic non-hereditary Parkinson's. That being said, there is a higher risk if you have a family member with Parkinson's. There is a higher risk of eventually getting Parkinson's than somebody who didn't have a family member with Parkinson's. But the idiopathic regular on age of onset Parkinson's disease is not hereditary. So you can't heredit one gene that will say that you will certainly get Parkinson's unless you have one of those rare early onset genetic forms of Parkinson's disease.
And Dr. Udow, is there a link between ADHD and PD? The impact on executive functions seems somewhat similar.
That's an excellent question. As far as I know, there is no link to say that if somebody has ADHD or had ADHD as a child, they would be more likely to get Parkinson's disease. But again, I haven't specifically looked at it. But you're right, the symptoms of ADHD and of Parkinson's disease are in some way similar. So there is trouble paying attention, although in Parkinson's disease, we don't tend to see so much of the H, which is hyperactivity. And I'm sorry, for people who don't know, ADHD stands for Attention Deficit Hyperactivity Disorder.
And the last question, will measuring the stickiness of the brain problem over time be any help in finding a cure for Parkinson's?
I'm not sure the stickiness, I guess that refers to the clumping of the proteins. So what I'll say about the clumping of the proteins is that we don't have a way of measuring the amount of clumped proteins in a brain of somebody with Parkinson's disease without looking at the brain under a microscope after autopsy. So we don't have a brain scan that can tell us how much clumped protein there is. We don't have a blood test that can tell us how much clumped protein there is. And we can't even look for the clumped protein at this point in the cerebrospinal fluid, in the fluid that surrounds the brain and spinal cord that we would sample when we do a lumbar puncture or a spinal tap. At this point, we don't have a way to measure how much clumped protein there is in the brain of somebody with Parkinson's disease. But there is a study that's coming out that's going to be trying to measure the levels of the clumped protein alpha-synuclein in patients with early Parkinson's disease as well as late Parkinson's disease, and in healthy controls as well. And they're looking to measure the levels of these proteins in the skin, in the colon, so doing a colonoscopy and taking a biopsy of the bowel, in the salivary glands, and in the cerebrospinal fluid, which is the fluid around the brain and the spinal cord. So that's a very promising study, because if we did ever develop a medication that would try to reduce the amount of clumped protein, reduce the amount of alpha-synuclein in the brain, we would need some way to measure if this clumped protein was being reduced. So there are studies that are trying to determine ways to measure the amount of clump protein in the brain, and we don't have them yet, but I'm optimistic.
We had one last-minute question come in, and then we'll call it the end of our presentation. Lewy body is generally understood to be a slow degenerative condition. Are there any cases you are aware of that can progress very rapidly? For example, the client is non-ambulatory in less than a month.
That sounds very unusual. Both Parkinson's disease and Lewy bodies are slowly progressive. So it would be very unusual to lose ambulation within a month of onset, but every patient is different, and there may be other medical factors that can contribute to troubles with ambulation as well. So I'm not aware of any cases like that.
Perfect. Dr. Udow, we want to thank you today, and on behalf of Parkinson Canada, I want to thank everyone for joining us. For more information on our upcoming webinars, or to view this webinar, after about 24 hours, we will have it archived on our website at www.parkinson.ca. You can also look for future notices on Dr. Udow's project and a needs survey coming to our website. Thank you, everyone, and this ends our presentation.